My name is Chris Burmeister. I'm with the Department of Health in New Mexico, and I oversee long-term care surveying and certification for the state. In New Mexico, today we're going to talk about the medical director's role specifically and citations surrounding deficient practice. In New Mexico, we have 76 nursing homes, SNF, NIFs, NIFs, etc., within a very vast, large state. And in this, we have rural providers, facilities in remote areas that require nursing care facilities and resources. So one of the challenges in New Mexico has always been provider recruitment, nurse recruitment. It's been a challenge across the board. That being said, one of the issues that we are encountering in New Mexico is some issues around medical care, medical oversight. As a result, we have seen an increase in citations surrounding specifically the FTAG 501, and we'll talk a little bit about the process of how we drill through and understand where that citation fits and how it ties into a medical director's oversight in ensuring that medical care occurs within compliance in the nursing home environment. To talk about noncompliance, how do we achieve noncompliance for this particular citation F501? It has to be in conjunction with other citations, specifically around these medical FTAGs, and I will go briefly into some of those FTAGs, and if these are surveyors that are watching this webinar, then you'll understand these FTAGs pretty well. And when you're citing these and you're thoroughly investigating these medical kinds of issues, it's very intuitive to be able to tie in this citation into that care area, into those care areas. F501 specifically, and the language is important in understanding this citation. It's the facility and the medical director's failure to coordinate and evaluate the medical care within the facility, including the review and evaluation and aspects of physician care and practitioner services. So this ties into not only the medical director, but also the facility and specifically the administrator. And as you know, there's an FTAG for being able to cite the administrator when there are certain things that we find deficient within the facility also. So there will be times where we will have the FTAG for medical director and an FTAG for the administrator in the facility. Key components of this would be where the physician is identifying and evaluating and addressing healthcare issues related to quality of care, and all these FTAGs surround quality of care and quality of life. Ensuring residents have primary care physicians, primary coverage by a physician. Another unique aspect, and I don't know if other states are experiencing this, but frequently the medical director also has a pretty heavy caseload within the nursing homes, which has always been a concern of where you balance being the medical director and overseeing medical care in addition to meeting the needs of the residents that you're serving within that environment. The physician and healthcare practitioner services reflect current standards, so obviously the medical director should be aware of what it is to be in compliance, what the regulatory requirements are, and how that facility can consistently achieve that balance, that requirement of being in substantial compliance for providing care to residents. Going on to the next slide, the medical director's role, and I think this is an important slide and important language taken directly from the guidance, and it's important really to understand this. Of what the medical director role is. It has an important role in helping the facility deal with regulatory and survey issues. So one of the last components on survey of what we do is we conduct an interview surrounding QA. QA, one of the requirements is that the medical director is participatory in that process, and as we all know, that's where you're looking at where there are system failures and where the facility really goes in working with the medical director in various disciplines, looks at where system failures occurred, enacts corrective action plans, and monitors the compliance of whatever was deficient and whatever they found through their quality assurance program. Key language in this, the medical director can help ensure that appropriate systems exist to facilitate good medical care, establish and apply good monitoring systems, and effective documentation and follow-up of findings. So this language specifically around what our 2567 is reflected as deficient, having them on board of being part of any kind of corrective action plans, but really most importantly of being aware of what's going on and what's transpiring in the facility around medical care. Areas of focus, and this is where we'll directly talk about the medical director's role and responsibility. These specific F tags tie directly to what the medical director should be helping the facility develop and implement. And whether that be policies or oversight, we've seen everything from, you know, how the medical director wants to interpret this kind of regulation. So it could be rounding, it could be meeting with the medical professionals within a regular period of time, it could be spot checking clinical records. Medical directors have various ways that they like to look at and evaluate how the medical care is occurring in the facility. Specifically, these tag areas, when we tag these areas as deficient practice, regardless of scope and severity, this is going to tie to having the medical director should be directly involved in these practices at some level. The first quality of care area is general quality of care around pain. And one of the things that ties with this F tag of how we start drilling through, and if this is a surveying audience, you know that the questions in initial interview is if residents are experiencing pain, and that triggers additional pathways that makes us explore how is the facility dealing with pain, how are they medicating it, how is the communication happening between the resident, the physician, how it's being translated to orders, how that is used to be able to deal with the resident's kind of pain. And there should be policies that clearly spell out the involvement of the medical professional and the medical director assisting in ensuring that a certain standard level of practice occurs in that, and how they intervene when residents are experiencing pain and what their process is in that particular area. Next care area would be F314 pressure ulcers. Clearly a medical kind of issue. And this is going to be the same thing. And notice the theme that is always the first part of guidance in all these F tags is determining whether the medical director assisted the facility in development and implementation of policies and procedures. So what this basically means is the medical director, are they aware of the policies and procedures around this particular care area, pressure ulcers? Our jobs as surveyors is what we're going to go in is determine what was their involvement. When we have a breakdown in a system where we have systemic issues around pressure ulcer care, we are going to follow through and find out, was the medical director involved? What is their general policy in dealing with pressure ulcers? How do they treat this? What's the communication between medical staff and the nurses or the care providers that are dealing with pressure ulcers? And it could be outside providers also providing wound care, the whole kind of drill through of how do we deal with somebody that has been designated as having pressure care or pressure ulcer care issues. And when there's deficient practice, we'll tie this all the way back to the medical director's involvement in that care area. The next area, another self-evident one, is catheter care. Collaborating and working with the medical staff on how they're addressing and ensuring that appropriate catheter care is happening, how they're identifying it, the symptoms, whether there's urinary tract infections surrounding this particular area, how they're facilitating care around those issues. Tube feeding is along the same exact line, and this is the part that people don't always necessarily connect with this. When we're going through the care areas and looking at this is the areas of nutrition, and there's a separate citation around nutrition, hydration status. So if we're finding through our surveys, we're going through and we're looking at the residents that are required that have tube feeding, we're looking at all these kinds of areas and drilling through these areas of what the processes are that puts these residents at risk for nutrition and hydration issues. and then following them all the way up to the general policy and process of how they maintain tube feeding residents. Therapeutic diets. A common one that they don't necessarily connect to the medical director, but is very specific in the language of what the medical director's part or involvement in this area is. We always think of the kitchen or the nutritionist being part of this, but they're integral in therapeutic diets. And the way that surveyors are going to look at this is clearly triggered not only by MDS, but also through some observation and interview of how nutritional diets are being delivered to some of these higher risk residents that require nutritional supplements or specific dietary plans. And physicians should be consulted with these residents and have a part in the development of the plan surrounding therapeutic diets. And this can trigger multiple other care area issues if we start finding issues around therapeutic diets. Another area of a more complex care area that can potentially cascade through multiple other areas of deficient practice is one of our more complex citations, which is F329, unnecessary medications. And this is going to involve not only the practitioner or the medical director, but also directly relate into pharmacy services. How they're identifying medications, that communication between the pharmacist making recommendations about potential adverse reactions, any kinds of issues that tie how the physicians and attending physicians are addressing those risks, how they're evaluating them, and how they're documenting what course of action needs to happen, whether they're taking the recommendation and taking action and the orders are changing, or if they feel that the current path of medication or whatever kind of process that's in place is accurate, that they're justifying why that they're doing it. And it's really this kind of communication between pharmacy, between the physicians, with the medical director, ensuring that the facility follows those processes to ensure that there's good communication and oversight of all issues regarding medication administration across the board, as far as medication interactions and things of that nature. I think this is the last one, influenza and pneumococcal immunization. Another one that is coded in the MDS, ensuring that obviously when it's not contraindicated, that these kinds of issues are being addressed at the point of entry into the facility and assessment. When it's flu season, which residents, as we know, elderly residents, highest risk for influenza, who is going to get it, who is ruled out, that's clearly documented, that when we go through that the physician has looked at that particular resident and determined whether they're a candidate for the influenza or pneumococcal immunizations, and that it's documented either way, whether the resident receives it or if the resident is not eligible for that and was ruled out for some particular reason. Feeding assistance is another one. Medical director collaborates with the facility to help implement the plans and policies surrounding this care area. Whether there's the use of a paid assistant, what kind of supervision happens, the criteria for this. Another common area that can be overlooked of how the physician or how the medical director interacts to ensure that feeding assistance occurs with residents that are designated to receive this service. And this goes along the line, obviously, when we're dealing with nutritional issues. But the physicians and their residents should be involved in this particular care area and oversight. Pharmacy. We've kind of talked about this in the unnecessary medication part. Obviously, the implementation of pharmacy and the pharmacy practice, whether it's the general review of medications with recommendations and making sure that there's a dialogue between physicians and pharmacy, and the nurses are being aware, whether it's dose reduction recommendations or times that dose reduction should occur, that it's being accurately documented by all practitioners in the facility, that information is being documented, and compliance is ensured that this is occurring within the time intervals of what needs to happen, in addition to any kind of irregularities or adverse consequences or potential adverse consequences. That's the basic overview. Those F tags specifically tie into F501. Within our state, what we're finding is when we start citing these care areas, these specific medical care areas, at that point, if we're finding substantial deficient practice in those areas, then we are tying it to the medical director F tag, the F tag of F501. If there are any questions or any conversations or dialogues that anybody has after this presentation, please feel free to email me. We can set up a talk with our team and how we analyze and look at this, provide any guidance, and of course we welcome how other states or how other surveying teams utilize this. We're always looking to refine and perfect our delivery of survey and how we look at and interpret these regulations. So a dialogue with any of the states or surveying agencies is always welcome, and we will act accordingly.